Hello, campers.
Hi.
Hey, so for once, I've actually managed to get two people on the screen. So we're not going to have the network issues and the internet issues, and hopefully this is going to come to your tablets, to your smartphones, nice and smooth. This is Andy Armitage.
Hi there.
We both work for a practice called Greenside. I've taken this opportunity to bring Andrew to your screens to talk to you about regenerative medicine, biological medicine, stem cell therapy, whatever you like to term it. Andrew's been working in this field for a long time. He's probably one of the most experienced people in the UK, and he is here to hopefully answer some questions. So don't hold back. If you have questions, please do ask. But what we're going to do is try and give you an overview about this area because it is still very new. So my first thing to say this evening, guys, if you are in the darkest depths of Cornwall and you go to your vets and say, hey, I've heard about stem cell therapy or biologicals, what can you offer me? Don't be surprised if they do a little bit of a blank face because it is still really new, but certainly if they're interested, they can get in touch and we can help them further. Hey Neil, nice to see you. So Andrew, tell us a little bit about yourself and how you got into it. So let's kind of set the scene.
Okay, so I started getting into regenerative medicine about 6 years ago, and it all started when I started using laser therapy in the practice, and I was seeing, you know, some awesome effects of laser, and that got me interested in sort of what was happening.
What were you using laser on?
For a number of you know, mainly arthritic change, but also soft tissue injuries, for pain, post-operative pain, things like that. And I started seeing some really good results with that, and that intrigued me, and I wanted to know what was happening. How is this laser light affecting tissues? So I started doing research into that, and started understanding how laser interacts with cells, and there was a study that showed that it activated stem cells, and I was like, oh, what's that? Stem cell? And started researching that, and at the same time I was becoming interested. The lab that I now use to culture my cells, one of their team was up talking to me about something else, and was mentioning that they were setting up a stem cell lab. And we got talking about it, and I ended up helping them by sending them tissue samples that we would throw away in the bin, bits of fat, you know, from a bitch stay or something, so that they could look at shipping of stem cells and how that affected things.
We'll come back to that and why that is important.
And looking into those processes, and as a to cut a long story short, they basically said, thank you so much for your help, and we'll give you 5 cases to try out. So I was like, okay, free of charge to the client. So I went away and thought about cases that I'd seen recently, and picked 5 cases that had severe arthritis that weren't being managed very well with drugs. They were on multiple drugs, still having issues. So we got those in and performed stem cell therapy on them, and all 5 cases did awesome, like unbelievable. And I was like, whoa, what, you know, what is going on here? This is amazing, and the rest is history. So I was convinced by those initial trial cases, and then just started offering it to all my arthritic clients, and then it's been a steady increase from there.
Just so you know, campers, Andy's got a slight advantage on a lot of vets in that he did a degree before he went to vet school. What did you do your degree in?
Human and mammalian physiology.
Okay, so basically understanding tissue behavior, how tissues heal at different rates in different ways, have different requirements. So your brain is already pretty clued up for that. I've only just started working with Andy, and I didn't have that kind of training, and I feel like I'm walking through mud half the time because my brain hasn't been trained the same way as you. You have a much better understanding of tissue and behaviour. So just so you know. Okay, so from there, I immediately hear that you kind of started off being quite subjective, and you've now built up a situation where you're trying to make sure that you've got all your T's crossed and your I's dotted. What are you currently doing?
So, I initially, when I started, I was seeing these amazing responses, and I started asking myself, am I seeing it? Like, this is too good to be true. So I started doing measurements to, track changes, what was happening after we'd injected these stem cells. So we started looking at stance analysis, which is weight distribution in all four limbs, and measuring joint angles and muscle measurements. And we used a lot of owner questionnaires as well to monitor that response and make sure we were getting some objective measures and not just seeing them back 6 weeks later after their stem cells and being like, yes, they're doing amazing. But how can we compare that to how they were before?
And how they might
bias.
have progressed if they were just staying as they were on the constitution.
Yes.
So just to butt in there, guys, this is really important, and it doesn't matter what platform you watch Cam on, be you on Holly's Army, Cam Pro, Cam main page. Something that all of us need to be aware of, whether we are the therapist, the vet, or the owner, is caregiver placebo. It is such a big deal. And there is definitely work showing that our subjective assessment of an animal's progress can be very, very flawed. And they did a study, it was a placebo arm of a pharmaceutical trial, and the animals that had placebo, 57% of the owners saw improvement when the objective measurements that were taken, no change. And what was even worse, 45% of the vets in charge of the case, they also saw improvement, no change. So we have to be very aware as professionals, as owners, that we can succumb to believing that there has been clinical improvement when there hasn't, and the dog situation hasn't changed. And as you guys remember, this is about the dog. This is the real, utmost importance, is that we're actually improving this dog's condition, both be it the disease and the pain. So that's why you start becoming much more objective. So just list some of the things. So any first opinion vets that go, oh, this is quite interesting. I'd quite like to look into this. What are the objective measures that you do per case, just to make sure that you're trying to be as scientific and factual as possible?
So every case, before as part of the diagnostic process, as well as monitoring treatment, we always measure weight distribution in each of the four limbs, and a normal dog should carry 60% of weight up front, 40 behind. So we should have a score of 30-30, 20-20.
Yeah.
And we can look at that and see if there's offloading of a particular limb or overloading. And that is normally because of pain. So if a limb is painful, they won't put all their weight through that, and they will offload it to another area of the body. So we measure that, and we take a number of different readings and get an average of that. We've also got a gait analyzer here, which is a treadmill with sensors on that takes lots of different readings for a variety of parameters like weight distribution, stride length, and the software gives us a score for each leg. So it's similar to the stance, but in motion. And
so you've got static, and then we've got dynamic.
Yes.
Yeah.
Because there can be some conditions that, like a shoulder tendon, potentially, they've got a normal weight distribution when they're just standing. As soon as you put that limb into motion, that tendon comes into play, and that will show up on the gait. So
has anybody had a tendinopathy? I have. Oh, it's horrendous. When you move it feels like a stabbing knife.
Yes.
But you can be quite happy. So,
yes. Yeah.
Okay. What else?
And then we always measure muscle diameter in each forelimb, so that we can see if there's differences between left and right side of the body. and we can also monitor that to make sure our rehab program is progressing as it should afterwards. I do a lot of goniometry.
Goniometry, the
yes.
bane of my life.
It takes time and it's difficult, but it's very easy.
I get suicidal when we have to do this.
So basically, what we're measuring is the joint range of motion. So my elbow, full flexion and full extension. We measure those angles. So things with like arthritis, you're going to get a lot of bony change in the joints and soft tissue restriction, and that stops the normal range of motion of the joint. If you've got a lot of bone production on the radial head, that's going to stop flexion. If you've got the back of the elbow osteophytes forming, that's going to limit extension. So we can measure those angles, and we know what's normal in Labradors. That's been published, and we can, we know what's normal for most dogs. And we can see if there's restrictions in the joint, and we can monitor that after treatment. Are we getting improvements or deteriorations in those range of motions? What else do we do?
This was the thing that I found really exciting when I started working here.
Pain ergometry. It's used a lot in humans, and we've got a pain ergometer here. And basically, it just measures pressure over this point, so we can apply it to an area of the body, and keep pressing until we get a pain response. So, that's hurting now, and we can say, right, that's 8 pounds per square inch of pressure on that area before we get a pain response. So, in our patients, it's a bit more difficult because they can't tell us. But we can look for indicators. So I've validated this for lumbosacral disease, so we can apply pressure onto the lumbosacral junction of a dog between the dorsal spinous processes, and keep applying pressure till we get a reaction. And that may be a licking of the lips, a head turn, but normally the first thing that happens is the animals just drop away from it. So we can apply pressure until we get that reaction, then take a reading. And I know, if there's an increased sensitivity to pain there, then they will react at a lot lower pressures.
I am going to do a completely unashamed big thing up for somebody that I feel very strongly needs to be known. Polly Taylor, who did a Facebook Live a few weeks ago, she runs a company called Top Cat, and they have those products. So if any vets that are listening, do have a look at Top Cat first, because Polly Taylor's and her team have validated a lot of these ergometer type products. Okay.
Yeah, and for any vets, get in touch, and I can tell you, ranges of what's normal, what's abnormal, locations to test it, and some of the pitfalls that we've overcome, whilst using this.
Yeah, because that's a very handy tool. So we're going on to and physical handling.
Yes. Yeah.
That is a pretty long, lengthy process, isn't it?
Yes.
Do your physical exam.
Yeah. So, well, we've got it down pat now, but we.
I haven't. I'm working on it.
That is very important, what we feel with our hands. So, we can feel for range of motion, we can feel for joint effusions, we can feel for crunchiness, crepitus in the joints, we can feel for muscle asymmetry, muscle loss, we can feel for trigger points, pain points within muscles, and we can get an idea where the problem lies by just feeling the animal.
But you can also use that to see if there is improvement.
Yes.
And that was the point of this little section here, is that we will talk about it later. There are a lot of people getting into stem cells. And one of the things that we have noticed is that the more people that are getting into it, the more potential that we're going to get poor results in hands that aren't maybe being objective or giving them a chance. So if somebody had a bad experience with stem cells and it was just on a subjective opinion, but actually the dog's going, yeah, my joints are amazing, but I'm afraid you missed the tendinopathy in my shoulder, which you didn't treat. But my elbows, they're good, but that dog is still lame and everybody thinks it failed. So one of the things that we're going to come back to later is that this exciting area needs to have a little bit more regulation and a little bit more of people singing from the same song sheet to make sure that we actually get accurate data rather than leaving it in the world of subjectivity. Okay, so you started using it in cases, you then started thinking, am I just seeing these, or do I need to actually start proving it? And how long have you been doing it now?
6 years.
6 years.
Coming up for 7 years, maybe.
And you started off doing it alongside small animal and large E's, and now you do it
100% of the time now. I deal with regenerative medicine cases, and we have a big referral load that come from all over the country, and also from Europe as well. We've had a few cases. We are the first regenerative medicine referral centre in the UK, and certainly been doing it the longest.
And this is where we get to do our acknowledgement, because I think this is really good for all of you to understand. You no longer are a owner of the practice.
No.
You have Sultan and Ez, you and your partner Neil, and you continue to work as a member of staff because this area of medicine is really interesting to you.
Yeah.
So just in case anybody thinks that this is just this wonderful pitch to try and persuade people to come here, it's not. I'm just trying to access somebody that has a lot of experience, is really passionate about it, and can hopefully get you detail. There isn't any pitch about this, there's no financial money exchange, and there is no pocket benefit for me and Andy being here to talk to you about it. Hopefully we're going to do the world of biologicals and regenerative medicine justice by talking about what is currently known, what hopefully the future holds, but how we can get there for the best of everybody, be it you the owner, be you the vet, be you the company producing the stem cells. So, cool, hopefully that's covered. So let's talk about a stem cell. What is a stem cell?
So stem cells, well, there's different types of stem cells. There's embryonic stem cells and adult stem cells. So embryonic stem cells come from an embryo, and they are able to produce every different type of tissue in the body. We all start from an embryo and we grow organs and limbs and a body, and that all comes from the embryonic stem cells. So these are sort of what's termed multipotent, so they can turn into any tissue type. So as the body's formed, then some of these stem cells differentiate into adult stem cells, and they are found throughout the body, but they are less potent. So they can't grow a whole new liver or a new limb, but they can produce certain other tissue types, so fat and bone, tendon, cartilage, and
they fall into categories, don't they?
Yes. So really, there is some work on embryonic stem cells, but for the purpose of this talk and what I use, we use adult stem cells. So they're harvested from an adult animal, from the fat is the best source, and then these cells, we can collect those, concentrate them, culture them, and then inject them back into the body, into sites of disease or injury or degeneration.
Okay. So just to pause it, a lot of people don't realise, they think that stem cells are only something that we have as a neonate, as a baby, but for us to be able to heal, and if I punch Andy now, for him to be able to heal, you have to have stem cells to be able to do tissue, and they're working all the time. And
so if I cut my arm, we're going to get bleeding and a blood clot, and the platelets in the blood clot, which form part of the blood clot, release all these factors that stimulate the stem cells in the surrounding tissues, which are normally in the fat, to move into that area of damage, grow new blood supplies, grow new fat, grow new skin, and heal the tissue. So stem cell therapy is just harnessing that healing properties of the stem cells, and they are the body's repair kit, and they should be thought of as the body's repair kit.
Which is quite exciting, isn't it? It's the most natural thing you can do. You're using the body to heal the body. So, whoa, natural. So, Tell us about, there's a bit of a thing happening. So first opinion vets, if you're watching this, you've seen the big adverts from Boehringer. They've now got the allergenic, but we're doing autologous. Explain the difference between that so people understand.
So there's two types, allergenic and autologous. So autologous means from yourself or from the patient. So we're taking fat, extracting the stem cells from a patient and injecting back into the patient. Allergenic is where you take stem cells from one animal or one person and put those into another animal or person. If you're crossing species, then that's xenogenic. Stem cells. So you're taking stem cells from a horse and putting them in a human, which is possible. And they work.
So the reason we got that little section in is that some people might have seen in veterinary press that, as I say, Boehringer have now got stem cells in a jar. You can have it on a shelf, and they've got
It's for horses. It's for tendon ligament injuries. So these are stem cells that are off the shelf, as it were, that we can use now. With allergenic stem cells, I'm just a wee bit cautious about, because we're taking cells from one person or animal and injecting them into the other. And stem cells do sort of evade the immune system. So the host does not recognize them as foreign. They don't have the immune receptors on the cell, outside of the cell, to flag that they're a foreign body. So it's possible you can do it, and there's not a problem. It doesn't set up an autoimmune reaction onto those stem cells. And stem cells are the body's repair kit. I see them as project managers. So they will turn on and off different cell processes. So they can secrete all these different chemicals, as it were, that can turn on and off inflammatory processes, stimulate healing, turn off degeneration. So they project manage healing, but they can also turn into other tissue types as well. So a question that has never been answered to me satisfactorily is, if I had somebody else's stem cells injected into me, and that stem cell then turned into a chondrocyte to produce cartilage, that is a differentiated cell, and that would have receptors on its surface that would then be recognized as foreign, because it's originally a foreign cell, and that would be destroyed. So I think with allergenic stem cells, maybe I'm looking at it too simplistically, but you get all the project management role of it, but I don't think you get the tissue formation role of it.
Okay, so you might get half cup full.
Yes, but I don't know. We need more evidence to see, and that may not be the case, but in my mind.
But if in the horse world it's now available in vials on the shelf, do you think that's where small animal might be heading?
I think that's where, there's a lot of big drug companies that are looking to have stem cells available on the shelf, ready to go for small animal and eventually human. And I know there's a lot of companies looking at that. I was surprised how quickly Boehringer were able to get that onto the market. Normally with the drug, that's 10 years of research and before that drug, and trials before it's entered onto the market. They seem to have bypassed a lot of that. So
it's not considered a food supplement, is it? It's just kind of wrong. Okay, so what we're dealing with, guys, is autologous. Okay, so that means that there is a process of harvesting tissue that leads to then taking that material and either immediately using it or sending it away for culture, etc. So explain the difference about that. So, because there are people doing different things around the country.
Yes.
So big first key difference, okay?
So there's a lot of different stem cell products, and some of them are termed stem cell when they really shouldn't be. And it covers a variety of sources of stem cells. So there's the sort of patient side systems where you can harvest the tissue, process it in-house, and inject stem cells within about an hour into the animal. So you can get the animal in, you can harvest the tissue, process it in-house, inject it back in, all under the one procedure. So the two procedures there are stromal vascular fraction and bone marrow aspirate concentrate. So stromal vascular fraction comes from fat. So you take a fat sample and then you use enzymes to break down that fat, and then spinning the fat so that the cells layer out. And we take, this is simplified, but we take, the stem cell layer, or the layer where the stem cells are going to sit in most concentration. Same with bone marrow, or BMAC, bone marrow aspirate concentrate. We can take a bone marrow sample, spin that down, and then take off the layer where the stem cells should be sitting. And then we can take that and inject it where we want to. So the problem with that is it's done in-house. So in the vet practice, we've got to be sterile about that. There is the risk of introducing infection either in the harvest or processing of the tissues. And we obviously don't want that. But also the numbers of stem cells that you're getting there is unknown. Very low. Well, it is completely unknown, yes. The company could tell you a value, but unfortunately they give you a value of total cell count, but that's not the total number of stem cells, that's the total number of cells in there. And are those cells viable? So you've taken them out, put them in enzymes to degrade the fat, you've spun them down in centrifuge, injected them back in. Are those stem cells alive? We don't know, because there's no way of testing for that. And we don't know what numbers are going in. So those procedures have benefits that it can all be done under one procedure.
Very appealing for a client who doesn't want to do two anesthetics.
And it's done. But what we don't know is what we're injecting.
Which is key when you're collecting data about whether this new field of medicine really, really works or not, is that we need to know what we're putting in. So
because if it works, fine. If it doesn't work, is it because we haven't put any stem cells in there, or they all died, or we've introduced infection, or or have we missed on it? We just don't know. So and I think products like this can give regenerative medicine a bad name because they're easy, they can be done in-house, but we don't know exactly what we're injecting.
So we're not going to go poo, but we're just talking about the practicality that if you did go in and you'd spent, I don't know, £800 and had it all done in one procedure and it didn't work, is that stem cells and biologicals out for good? And are you going to tell all your mates that stem cells don't work? Can you see how when this data gets out into the public realm, it potentially has the ability to really skew people's opinion about it? Okay, so there's that. Then what's the other side of the fence to patient side? What other option is there?
So the other option is culturing of stem cells. So we can take fat or bone marrow and send that off to a laboratory where they will isolate the stem cells and then use culture processes to grow up those stem cells to a specific number, and then can supply those to the vet to implant either fresh or you can cryogenically freeze them. So if they're grown fresh and sent out, that has restrictions on when that procedure needs to be done to implant them, and they may leave the lab fresh out of culture, 100% viability, and we know how many stem cells are in there, but at the time they're couriered to the practice and then injected, there's a time lag there. And what we do know is stem cell viability drops off very, very quickly. So again, at the time we come to inject, we don't know exactly how many stem cells are still alive and what dose we're giving. So they may have left the lab at 1 million cells, but when we inject, how many of those are alive? Is it half?
And that's the kind of numbers you are dealing with as well. So when you said 1 million cells, it wasn't 1 million cells. It was actually, you're putting over 2.5 million per joint minimum, isn't it?
Well, we've worked out, a dose really, where we sort of see improvement. What I don't know, is there an upper limit? Can you put too many in there? Yeah. But certainly we're seeing some great effects with greater than 1 million cells per joint. Yeah. Normally, it depends on the size of the animal. But I like to put in several million if I can.
Yeah. So, okay. We have got questions. We are going to come to them. Please do not worry. We will have a look at your questions. Okay. So that's already just highlighted to the public that this term that's floating around, stem cell therapy, regen, biological, is very wide. There's a lot of different people doing different things out there. And that's why the data that's coming out can be really quite hard to interpret. And we've got some amazing people in Holly's Army. I've seen a few of them following tonight, who actually really do a lot of research before they introduce any new therapy to their dog. And they look at current data that's available and sit there thinking, well, there's not enough evidence yet, so I'm not going to go there. Hopefully, over the next 5 years, more and more data will come out and it will be more of a uniform approach. So instead of people pooling everything under one roof, we start actually subdividing and looking at data as individual harvest, culture, transport ways.
I think, it is a very new technology, so research is in its infancy. But if you look, there are thousands of research projects currently on stem cells because it's such a paradigm shift and they hold such great potential. And there is a lot of published work. It may not be in, the top end veterinary journals, but there is a lot of published work, and I think what we know is what stem cells can do in the lab. There's been lots of projects looking at the growth factors and the cytokines and things that stem cell releases and the potential effects of those, what happens in the test tube. So we've got great data on that. We've also got very good data on tissue generation. So stem cells can form cartilage, can form bone. We can do all this, in the lab. What we're lacking is what happens when we put that in an animal, and what effects are we seeing these same effects. So I think what we should take a big take-home message of all these different what are called in vivo studies, so within the animal or person, is that stem cells are safe. So there is, I haven't found one study that says that they injected stem cells and there was a problem. The side effects are, there's no side effects. So they are very safe, and that is for allogenic cells as well as autologous cells. So that is one good thing. But there are lots of studies that look at the effects, but it's small groups of animals, and some of these studies are not particularly well designed in that you haven't got controls and you haven't got the numbers involved. So it becomes difficult when you start interpreting that, is that solid sort of evidence? But that is the case with any new technology. We've got, as the research grows, studies are better designed. Once we learn more, we need to know what else we need to look at, and these things happen. In the patient, though, it is difficult. It's very different lab work and trials in there. That there's a lot of difficulties where we look at clinical outcomes.
So I did a workup on a dog today, and it had mild elbow dysplasia, bicep tenosynovitis, supraspinatus tendinopathy in both shoulders. It had trigger points in both latissimus dorsi. It had trigger points down its back. It had sensitivity down the dorsal spinal processes. It had changes within the intervertebral disc in most of the lumbar vertebrae. It had mild hip dysplasia. It had iliopsoas fibrosis, and it looked like it might have a little bit of an upset stifle. And then, if somebody was to put stem cells just in the stifle.
That is, stem cell therapy is a targeted treatment.
Yeah.
So you're putting these stem cells into an area where it's going to project manage the healing, hopefully produce new tissues, new cartilage, repair tendons. But if you've got a hip and a knee problem, you're just putting them in the knee, you're unlikely to get any benefit from the hip. So that's where diagnostics is very important. A drug, a pain-killing drug, you take that orally, it goes in the bloodstream, goes throughout the body, and it will treat pain and inflammation wherever it is. With stem cells, yes, you can give them intravenously, but if it's a joint pathology, you want to put them directly into the joint. Then you can guarantee the highest numbers, but you've got to also treat all the surrounding muscles, tendons, because we know that they are very commonly affected.
Yeah.
And I think the classic example is elbows.
Yeah.
We see a lot of cases of elbow dysplasia, and I would say pretty much 90% of them have concurrent shoulder tendinopathies. And I think it's a big reason why dogs with elbow dysplasia will have a very stable pattern of, they're doing well on a non-steroidal and exercise management, weight management, but then they suddenly deteriorate. And I think that's not necessarily always, we've got a flare of arthritis. I think that's when the shoulder tendons start to struggle. And so if we go in and put stem cells in the elbow, we're not treating the actual cause of the lameness that may be more, at the time. So it's very important to have a complete diagnostic picture, and we need to treat these animals holistically. And when I say holistic, I don't mean with herbal medicine. I mean as a whole. So, we have to identify all areas of pathology and target that with the stem cells and treat it. And then that's where we're seeing the best improvement.
Yeah.
When I first started doing stem cells, I was just targeting the worst areas affected, and we was getting, a good response. But it's when you start looking at the bigger picture and start treating all the other areas, that's where you start getting these awesome responses, and you're like, And
that's a little sidetrack opportunity for me. So when people kind of wonder what the benefit of having like a physio or a rehab person added to your arthritis management plan, say stem cells is not in your thing, PRP is not in your thing, but you're wanting to manage your dog to the best of your ability, having somebody that has got a rehab focus is a really good addition to your plan, because they'll often be able to locate other problems that are contributing to the bigger picture of pain. So I often talk to people about, if your dog is 100% pain now, 10% here, 20% there, 30% here, 50% in the elbow, but actually got all of these secondaries that we can alleviate. So do think about that. Tissues are a bit of a domino effect. You can't have one problem over a period of time and for it to not influence others. And the lovely Ian Self, he has said, if you've got arthritic pain, you will have pain elsewhere, because that dog will have weight shifted, they will have adapted their posture, and they will have created secondary. So you've got to go and find it. So that's a little sideline just for people that are like, this is interesting, but it's not going to be my cup of tea. You can still get a little take home.
I think even if you're not going down the stem cell route, diagnostics are so important, because we need to know what tissues are involved, what the process is, so that we can best treat that, whether it's with stem cells, drugs, physio, hydrotherapy. We need to know if it's an iliopsoas tendon issue. Maybe hydrotherapy is not the best thing to do initially, because you could exacerbate that. So diagnostics is key.
Let's treat the campholysis to it just a little bit about tissue, and we'll come back to stem cells, because I think this is a really big opportunity for you to talk to people about tissue healing, going back to the real foundational understanding. Because I know that I wasn't taught this. We get taught a lot at uni. I was there for six years, but I wouldn't say that we focused a lot on tissue healing. So just explain what I'm fishing for, because tendon, ligament, arthritic, so that owners can understand why a lameness might not just respond to non-steroidal.
Well, with any, if we're talking about arthritis, say of the elbow, we start getting restriction because we've got new bone production. So that joint is not moving through a range of motion. So the joint sits in a joint capsule, which is like a fibrous bag. So if that fibrous bag is not being stretched, as it should do in a normal range of motion, over time it can become contracted, and there's inflammatory change in the joint, which causes thickening of the joint capsule, and we can get some sort of fibrotic scar type tissue. So the joint capsule becomes less elastic, it's thickened, less stretchy, and that further reduces the range of motion. Then that has a knock-on effect on the muscles that move the joint. If those muscles aren't being stretched to their full extent for a range of motion, then over time you're going to get contracture of those muscles, muscle loss, replacement of muscle fibers with scar tissue, and you get this deteriorating effect that basically spreads from the joint to the surrounding soft tissues. And then there's traumatic events as well, that can damage tissue.
And then if you're weight shifting off, you get the wastage that comes with that.
So the muscles contract out, and then you're overloading if you're right fore lame, you're commonly overloading your left hind, and then the forces go through your spine in a diagonal and not down the spine as it should. You're unbalanced, then the high motion areas of your spine, like thoracolumbar junction, lumbosacral junction, those discs start to have abnormal forces applied to them on a constant basis. They become unhappy and start degenerating, drying out. And then you might get lower back pain because of that, and then you stop extending your back legs as much, because to do so you flex your spine. So the tissues in your hind legs then start to contract and fibrose, and then we start getting problems there. So this is what I see. What may have started off with an elbow problem has now gone throughout the whole body, and we're seeing tissue changes in the spine, in other limbs, and in other tissues. And then when we come to treat that, yes, we give them painkillers, these things are painful, but you're not doing anything to the underlying process or the fibrosis. Non-steroidal is not going to change that muscle contracture or the joint capsule thickening. Some of them have some anti-inflammatory effects, but
I think there's that belief that if you can remove the pain, you can encourage normal motion, and weight bearing will just unravel the damage that's been done. But that's where rehab comes in. That a dog's not going to go, I feel a lot more comfortable now, I'm just going to go back to the way that I walked 4 years ago and completely rebuild myself. They're going to still use the path of least resistance and movement. That gives me a chance to do just another little tangent of something that came up this weekend. And it comes up all the time, about when people talk about if their dog's limping, if their dog's guarding, if their dog's got behaviour change. I have a huge respect for dogs. Like, insane, because they come in, they're waggy tails, they greet us, and often I see them walk in and go, am I going to find anything? And then when you slowly go for your clinical exam, you're like, and there's not something else. They manage to contain and cope with pain incredibly well.
Incredibly well, yeah.
And if anybody's looked at our 5x5x5 tool for practice use, which you can find in downloads and resources on the Canine arthritis.co.uk website, it's a grading, scoring, and staging scheme. Pain scoring, we don't have 0 in arthritis, because generally, as Ian Self has said, that once you have an arthritic problem, there's always going to be an element of discomfort somewhere. So we start 1 to 5. We don't have a pain score of 0. We find that that's really helpful for owners to understand. It keeps them a little bit vigilant. It keeps them kind of aware that this is a progressive disease. And the truth is that they're always weight shifting a little bit. They've always adapted their posture. There's always going to be something. So back to the whole Holly's Army. If somebody says to you, your dog is very likely to be in pain, don't take it the wrong way. It's true. Sadly, it is true. They have amazing coping strategies. They're amazing animals, and job said. Right, let's go back to stem cells and the diagnostic workup. Sorry, I'm not flu. I'm going to cough. It's not Andy's perfume. I actually am coughing. So let's talk about diagnosis again. Something that is really new and upcoming, and a lot of CAM followers won't know about this yet, is you've heard of X-rays, and you've heard of CTs, and you've heard of MRIs. There's a new diagnostic workup tool that is not so readily available, but very interesting. What is it?
It's not new. That's the thing.
New in the small.
This is what blows my mind, is musculoskeletal ultrasound. So, vets have been using ultrasound for a long time for pregnancy diagnosis, and abdominal scanning, and then cardiac scanning, looking at hearts. But for the small animal vets, it's rarely used for musculoskeletal work. The equine vets use it all the time. Horses get tendon ligament issues a lot, and ultrasound is amazing for looking in at those structures. So X-rays are brilliant for looking at bony change, looking at joints, but X-rays not very good for soft tissues. So then you can use MRI, sometimes CT scans. CT's more of a 3D X-ray. MRIs can be quite good for soft tissue. But ultrasound has a lot of advantages. One, it's a lot cheaper than an MRI, less invasive. They don't have to be anaesthetised for it. A lot of the time you can do it conscious. All we have to do is shave the hair, and it gives us a lot of information, so we can look at the soft tissue structures, not just look at them, we can see those soft tissue structures in motion. So that's very important for muscles and tendons. If we're looking for a problem, if we can see how that tissue is moving in real time, that's really interesting. And and as we've been saying, it's not just about the joint for arthritis. A lot of the time it's those compensatory soft tissue changes that are also having an effect for the lameness, and we can diagnose those in a very easy way. But
you need a diagnosis.
You need a diagnosis, but it is quite specialist in that you can look at an ultrasound image and it can just look like a load of black and grey dots.
It really, really can.
So I've been training Hannah up, and I'm like, look,
I'm like, really?
But you're getting there. It is slowly. It is a long process, and you just have to keep doing it and look at normal structures, and then look at abnormal structures. There is some pitfalls. You can get a lot of artifacts. I can create any disease pathology pretty much by just changing the probe. So we need to know what we're looking at is definitely there, and it's not an artifact.
So the
but
reason
it's
that I
interesting.
mention that is, again, to just reinforce with you guys that going back to stem cells, going back to any of these intra-articular approaches, and we will talk about PRP and we'll talk about other things that you can put in the joints. We're going to run out of time, but we're going to do this. Please remember that the body is quite complex and they don't just isolate the problem to one joint. Very soon in the disease process, there has been other things going on with weight shifting and tissue changes. So when looking at this intra-articular and especially the biological world, we have to really know what you're dealing with to be able to make the right choices. And when you see a lot of stuff in the public domain or you hear bad press, are these people fully aware of what exactly the process is going on in the joint, how severe it is, are other structures involved, etc. So the reason we spent time there is I just really want people not to think that it is just gold dust that they can go and get down their road. It's got to be done with a lot of thought into it. Let's have a pause here and just answer some of these questions. Sounds amazing, but I'm guessing this won't be a cheap treatment option. Can you give any idea of how much it would roughly cost? And do you know if pet insurance companies would cover this kind of treatment?
It's very difficult to give an idea of cost. It depends how much diagnostics you need to do. And a lot of my cases, we're doing a lot of diagnostics, lots of x-rays, musculoskeletal ultrasound and things as we've just been discussing, to get a diagnosis. And that is the first stage, and you can spend quite a lot of money doing that. I think as a very, very rough guide, if you're looking to treat with regenerative medicine, you're looking between £3,000 and £7,000 as a very rough guide, and that would include diagnostics as appropriate, treating joints, soft tissues, tendons, ligaments as required, stem cells with PRP and laser therapy and a rehab program.
And that
afterwards.
includes the fat harvest?
That includes the fat harvest
So
and the cell culture.
2, if not 3 stage, isn't it?
Yes, yeah.
Okay.
Depending on the severity. A lot of insurance companies do pay for it, but not all. And you should be able to find that in your policy document, whether they cover it. I haven't found an insurance company that doesn't cover PRP.
Let's talk about PRP. I was going to do exactly the same. Tell them what PRP is, because a lot of people think that they're the same, and there's a massive price difference and there's a very big availability difference between the two. So what is PRP?
So PRP is platelet-rich plasma. So it's basically we take a blood sample and spin it down to concentrate the platelets. We get rid of the red blood cells and the white blood cells, or some of the white blood cells, and then left with platelets, and then we can concentrate those and resuspend them in the plasma, which is the clear part of the blood without the red blood cells. There is a filtration technique as well, so it's like in a drip bag almost, and the cells go through a filter and collect the platelets. I'm not a great fan of that. The other ones are centrifuge based, so you spin the cells down to concentrate the platelets, and then we're left with this platelet-rich solution.
And what do platelets do normally, so people just can catch up? Why are they in the blood?
So platelets, their primary role is in clotting. So in the example that we spoke about earlier, I cut my arm, you're going to bleed. When the blood is exposed to air, the platelets are activated. So those platelets then start sticking together, and they also release a chemical process that causes the formation of fibrin. So fibrin is a proteinaceous fiber that sticks together and forms what's called a fibrin clot. So you've got a cut, bleeding, stem cells the platelets activate, they all stick together, and you get all this fibrin strands produced. So you've got platelets and these protein fibers stuck together in a meshwork, and that forms a clot and stops the bleeding. So it plugs the hole. So then what happens is those platelets alert the surrounding tissue to damage. So they what called degranulate. So inside them is these balloons called alpha granules that are full of all these growth factors and cell signaling molecules. So the platelets release that, the balloon bursts, and all these lovely cytokines and growth factors are flooded in the area of damage, and that signals to the surrounding cells to, hey, we've got a problem here, come in. So it draws the stem cells in. It also stimulates blood vessel development, so you'll get these little blood vessels start growing into the area, stem cells coming in, other cells are recruited, it modulates the inflammatory response and kickstarts the healing process.
So you just did a bit of a key thing there. It brings in the stem cells. So for people who didn't realise that there's a lot of stem cells in your body dormant, waiting for the call. Oh, you want me? Okay. So the PRP can hopefully do that. But again, we don't know necessarily how many stem cells and what the process is.
And if the stem cells can get there. So that's if we go back to arthritis and we put PRP in a joint, it's going to try and recruit stem cells, but can they get there? And have we got arthritis because all the stem cells in the knee have been used up? Yeah,
it's really fascinating.
And you get the stem cells enter a joint via the subchondral bone underneath the cartilage, and with arthritis you get thickening of the subchondral bone, sclerosis, that cuts the blood supply off, and these migratory pathways where stem cells could come from the bone marrow into the joint is cut off. So
and that might explain it. Well, it does potentially explain why PRP tends to have a short-lived effect. It's used quite a lot.
It could be useful for pain and inflammation, turning off inflammation, and stimulating tissues to help heal, but it's not providing any cells like stem cells to grow new cartilage and things like that. So it tends to be short-lived, and you tend to need more than one injection.
Yeah, I was just about to say that. So don't be surprised if your vet who offers PRP is suggesting, potentially up to 3 treatments, and some people do them even a week apart. I know that was over in America.
Yeah, they do. Yeah, or at least every 2 weeks for 3 occasions.
Yeah.
And if it hasn't worked by then it's not going to.
But again, there's a massive variation in how much PRP, how much platelets. And a very simple thing, first opinion vets, if you're watching this, and it's so simple, is that put the blood through your hematology machine prior to spinning it out, and then put a small sample of your PRP through the machine again. You only need a very, very small quantity. You're not going to waste any. But just know that what you're putting in is actually concentrated PRP. So
there is so many systems available in the UK for producing PRP, and all the companies will give you data of ours produces the best PRP, but the majority of them are from a human from the human side, and what human and canine platelets are very, very different.
Right.
And they don't behave the same. And when you put them through these machines, they don't behave the same. So a lot of these products, in fact, all of them in the UK, bar one, has not been validated for dogs.
Right.
So a company may sell you a PRP machine, a centrifuge, and concentrating device, and you think you're using PRP, but are you?
So get one on trial, and then put your blood through the hematology machine and see if it's delivering the goods. So
there's some of the. There was a validation trial published that looked at 5 commonly available machines, and some of them didn't even concentrate the platelets, and one of them actually removed the platelets, so it actually produced platelet poor plasma. So you're injecting this
PPP. Let's have some.
We're putting loads of platelets in here when you may not be.
Might not be.
And then that gives regenerative medicine a bad name. Because, I had PRP, nothing happened, or my dog got worse, because you, instead of putting loads of platelets in, you put in loads of red blood cells and white blood cells that can inflame the joint. And then, PRP doesn't work. But did you use PRP, and what was its composition?
Very good point. So we've got a question here. At what point would you be able to try this approach? Is there a degree of arthritis when it would be too late to try?
Very good question. No. I've treated dogs from 5 months of age right through to 16, 17. And I've treated very early identification of arthritis through to end-stage multiple joint spinal arthritis. I think, obviously, the sooner that we can get in, the better. With stem cells, I'm not curing it, I'm turning back the clock. So we can turn back the health of that joint to an earlier time point where the health of that joint was better. So if there's very few changes, we've got a chance of completely, turning back the clock. If we're at the end stage and we've got no cartilage left and we've got all this new bone production and everything else, we're not going to get a nice new joint. I can't grow a new joint. So yes, you can use it in any age of animal and any stage of arthritis. And I think some of the most dramatic responses are in those dogs that have got multiple advanced arthritis, because they're in so much discomfort that's not being controlled by drugs. All of a sudden, you're giving them something that's just stopping that inflammation and helping with the pain, and they come back to life again. But I think, for the longevity of effect of stem cells, probably the more advanced and the older the animal, that longevity is going to be reduced.
That's something that you guys really need to know, and I think me and Andy agree very much on this, is that especially if you've got a lifestyle or a habit or something that keeps triggering and is exacerbating that problem, you're not going to get the best out of it. So you regularly are seeing them ideally 12 to 18 months back for a top up. But you are also having people that don't take advice about lifestyle change. They don't get the weight off the dog. They don't stop doing those things that we know exacerbate those joints, and they come back sooner.
Yeah.
So again, this is a part of a multimodal approach, and this is something that I think really needs to be said, is that it's quite an expensive, approach. Don't be daft, don't think it's going to suddenly wrap your dog in a blanket and make them suddenly super dog. They don't. It has to still be used as part of a multimodal approach.
And, that's why we also, have dedicated rehab programs for them afterwards. We make sure that, they're going to lose some weight, have physio, have hydrotherapy. We can turn off the pain in the joints. We can grow some new cartilage. We can get better range of motion. We can address the tendinopathies. But what we then need to do is get the body more balanced again, get these joints better range of motion, and that's where physiotherapy and
which leads me lovely onto this one. My Labrador had stem cell therapy 3 months ago for severe arthritis in elbows. Sadly, no change in her. She's 10 years old. Could you advise? I think this is a really good point where we can just talk a bit about rehab, about physio, about hydro. Hopefully, we've answered a lot of your question already. Is that it's part of a plan, and you have to consider there's lots of different tissues influencing that joint. We've mentioned that the problem might actually be in the dog's shoulders. We've got ligaments, tendons, muscles. It can be a deep-seated trigger point somewhere, very in that peripheral limb. So get a good diagnosis. Go back to a blank slate.
What I say is stem cells always work. Okay. You will always get a response. If you don't, you've missed something. So you've either not diagnosed correctly, or there's more things going on, or there's an underlying medical condition or drug that's interacting with the stem cells. So if you haven't had...
the stem cells weren't happy.
Or you've used the inappropriate stem cells. So, for Michelle, the questions I would ask is what stem cells were used? Was PRP used in combination with them? with the shoulders looked at, because as I say, pretty much every dog with elbow dysplasia will have concurrent shoulder
And this is something that you've learned.
tendinopathies.
You as you said at the beginning, you were injecting elbows and going, you did okay, but you've not done brilliantly. And it was only through trial and error 3-4 years ago.
Yes.
You go, well, there's something not right.
Yeah.
So
And
don't
then-
blame your vet.
No,
Definitely
yes.
don't blame your vet.
And the trouble with shoulder tendinopathies is, an X-ray could look perfectly clean, and it's not until you put the ultrasound on that you see these changes. Another thing that has a negative prognostic indicator for stem cell therapy is for elbow dysplasia is we're going to get controversial. Is
I'm kind of
is elbow arthroscopy. So elbow arthroscopy is commonly used to treat elbow dysplasia. It's used in the diagnosis as well as treatment, removing fragmented coronoid processes, curating out damaged cartilage. And what I found is dogs that have had arthroscopy and then subsequently have stem cell therapy do less well than dogs that have got the same underlying elbow dysplasia, fragmented coronoid process, but they haven't had arthroscopy.
Okay.
So, but
and there is more work beginning to suggest that. So it's not just your opinion. There is a.
I mean, this is something that I'm seeing, and I don't advocate elbow arthroscopy.
And we're going to do that in another Facebook Live because this is going to go crazy.
That is very controversial, and I wouldn't be. No. I probably wouldn't be supported by a lot of orthopaedic surgeons.
No,
but
and
it's just from what I'm seeing, and it goes back to tissue healing and things like that. Arthritis forms after traumatic injury to cartilage and a joint, and if you're going in there and cutting out bits of cartilage and taking bits of damaged bone out, that is going to speed the progression of arthritis, and I think that's what we're seeing. I would much prefer to get in there early with stem cells, and we seem to get better results. But that's a very
it'll be an interesting
opinion.
topic, and we might take that to Cam Pro page. Just to help the lovely, where was she? Michelle Smith. There are other things coming out, and I'm really excited to say that we've got Diane Messam from Davies, who is their head physio. She's going to be here tomorrow at 6 p.m, where we're going to be talking about the physio involvement. Is that you or me?
Sorry, it's me.
It's you. So please listen in to Diane. I'll try and direct questions about elbows with her line of work. We've also got, amazingly, Professor Matthew Allen, who's going to be on later this month talking about shockwave, which is something new that's coming out. We will also try and get people on about laser, ultrasound. There's other modalities that can influence. So don't give up. Also, there is intra-articular steroids.
There is.
There is. And now I know that you hate it, but in situations where people don't have anything else available, there is a palliative care basis to it, isn't it?
Yes, definitely. I mean, a steroid is a very potent anti-inflammatory, and if you've got an inflammatory basis in the joint that's causing pain, steroids can be very useful to deal with that, get that under control. There are other effects of that, and potentially can have effects on cartilage and things, and systemic absorption. So you have to be careful if they're already on a non-steroidal and things. But yes, that is. And
again, would have to be included as part of rehab plan.
Yes.
You wouldn't just put a steroid in a joint and then just say, see ya, it's going to be fine.
Unfortunately, there is no quick fix.
No. There's a little question about using it in digits. Can stem cell treatment help dogs with digit arthritis who have some bone degeneration in the joint where there is no cartilage left?
Yes, we do a lot of work in the digits and in these small joints. They're difficult to access, and you have to use concentrated stem cells in small volumes. But I see a lot of dogs that have digit OA, and this can be a significant cause of lameness. So if we're finding that and the animal's going for stem cell therapy, we would definitely treat the digits as well.
Yeah.
And yes, you can inject directly into the digits, into these interphalangeal joints and metacarpal phalangeal joints.
Somebody asked about Arthritic. I think it's now called Aquamid. I will seek somebody to talk about that. I know it's been more widely used than it is being used at some referral centres around the UK. But I will get you more details in the next few weeks about that. It's a completely different kettle of fish. It's not biological. It's much more in there looking at trying to improve the elasticity of the joint capsule.
Lubricate the joint.
Lubricate the joint. So.
But that does. There's some work that I did with Arthritic and stem cells, and I can tell you, if you combine stem cells with Arthritic, it kills the stem cells.
Yeah.
That is not a toxic effect. That is, I think the stem cells just get smothered by the Arthritic. It's a polyacrylamide hydrogel that was initially used in as a facial filler
and in your bladder,
in cosmetic surgery,
and your sphincter
to tighten up your sphincters. It shouldn't be used with regenerative medicine.
Can it be used with PRP though? Because the cells are degranulating.
Yes, the cells are degranulating. I can't answer that. I can only answer for the work that we've done looking at stem cells. If it smothers stem cells and kills them, does it do the same to platelets and doesn't allow them to degranulate? So don't know.
It's a work in progress, guys. So we've covered quite a lot, and we're already an hour and 11 minutes, and we haven't done 10 top tips. I haven't prepped Andy for this. But they're very useful, and we're now beginning to distill them out of these Facebook Lives and have them as a standalone entity for short, sharp advice for the people that have no concentration span. So, first of all, I'd like to say a massive thank you to Andy for given up his time to do this. I hope you guys realise this isn't a pitch for any practice in particular. It's not a pitch for a therapy in particular. I'm actually just trying to access any resources that we can to try and get you really good information in a very down-to-earth manner with no white coat effect. So thanks, Andy, so much for doing that for me.
No problem.
So 10 top tips. Thinking about it as a first opinion vet, as an owner.
No, I can't do that.
I can't. Sorry, all right.
I need to have a regenerative focus.
Okay.
We're going to mix it up tonight.
Okay, you can mix it up.
Because otherwise my brain just goes blank.
He's in regen mode. Okay, so what we're going to do is I will start with number 10, and I have to use my fingers. I don't know if anybody notices, but I get lost very quickly. So number 10 for me is always going to be weight control. And how do you feel about this, Holly's Army people? If we see an overweight dog on Holly's Army, do we say anything? We're doing it with the best intention of mentioning to your dog that they've got too much weight there. Are you going to take offence? Or are you going to see, actually, it's with our best intention? Weight has a massive negative effect on OA, doesn't it?
It does, definitely.
And I think anybody with an arthritic dog, your priority is to get advice and support to get them down to a body condition score 4.5 to 5 out of 9. Please do it. It makes a big difference. Number 9.
Well, following on for that, I don't know how true this is, but it seems to work. For if an animal's struggling to lose weight, maybe not reducing the amount fed, but the way you feed it has a big difference. And I always give this advice out, and it seems to work. Feed 2/3 of the dog's ration in the morning, and 1/3 at night. And I haven't got any scientific backing for it, but in my mind, if you're eating the majority of your calorie intake in the morning, you've got that whole day to burn that off. Whereas if you're eating lots of calories at night, then your liver's just going to turn that into fat.
And there's a lot of stuff like that. Yeah. Victoria Beckham supposedly only eats a peanut every hour. Yeah.
So, sometimes dogs, you keep reducing the food and they're not shifting that weight.
Yeah.
And all of a sudden you're just like, well, feed more in the morning and less at night. And that can be the trigger to start losing weight.
Yeah. So guys, it's not just what you feed and how much you feed, it's how you feed. And that's really, really important. And we can play with that a bit later. Number 8 for me, it's my favourite, flooring. Cam was created because of flooring. I couldn't believe the amount of houses I was going to see these arthritic dogs and seeing them just skating across the floor and just thinking that must hurt, but because they don't vocalize, because they are amazing animals, they didn't, owners didn't see it as a problem. So please look at your flooring. Laminate, wood, tile, they're all slippery. Their pads are not Spider-Man suction cups. They're there to protect them from the terrain that they walk on. They're hard, they're keratinized, they don't offer grip. So trim the fur, clip the nails, put your rugs down. Number 7.
If your dog is diagnosed with elbow dysplasia, get the shoulders checked.
Oh, that's a good one.
I see it so frequently that we have, concurrent shoulder issues, and I think that is a lot of reason why some of these dogs are just not improving to conventional therapy. So think if you've got elbow dysplasia diagnosed, think shoulders and rule it out. Get it ruled out.
I'm going to add to that. Number 6 for me is that there is always going to be some kind of soft tissue discomfort. They cope amazingly well. They body weight shift. They use their body differently. Muscles that used to glide and smoke, like flow over each other, are starting to be pulled in different directions. Myofascial pain, trigger points, hypertonic muscles, all of those. Massage, physio, amazing, big game changers. So have a look. Number 5.
If you're thinking about going down the regenerative medicine route, whether that be PRP or stem cell therapy, ask for validation data.
Yeah.
You now know what you need to look out for, and you'll be able to ask the right questions. Where are the cells coming from? How many cells are going in? With PRP, what concentration of platelets? What is the composition of that? Because it is very important, and it could have a big impact, on the outcomes of treatment.
Very good one. I think number 4 for me would have to be honest about your lifestyle and don't bury your head in the sand. Okay, if you had a knee problem diagnosed in yourself, and every time you played football for 2 days afterwards it was really quite uncomfortable, you'd start saying to yourself, I'm not going to play football anymore because I know I'm just making my condition worse. Animals do say that to us, but in the heat of the moment, they'll be playing. So look at the real, logical side of things. If you've got a dog that's got elbow OA, shoulder tendinopathies, kicking a tennis ball around is not going to be in their best interest. Change it, spice it up, hide the tennis ball, go and put it in long grass, choose a different activity, but don't rub salt into the wound, basically. Number 3.
If you're changing a treatment plan, or even going along with a consistent treatment plan, always look for outcome measures. So you've got to monitor what you're doing at home is having an effect, either positive or negative. So use outcome measures to track that. And if you're having different treatment options, always bear that in mind. And Cam has a massive resource with that, with recommendations for how to track changes in your dog.
Yes. Number 2 for me is, because it's something that we seem to preach on Holly's Army a lot, please don't fear drugs. This is about the dog. It's not about your opinion about how you feel that medication, etc. Let's look at the dog. If the dog is in pain, we want to get rid of that pain as quickly as possible because of many reasons, ethical, and the fact that we know that pain won't go away. It can actually get worse, and it becomes uncoupled from the disease process. So if your dog is in pain and your vet is suggesting an anti-inflammatory or further medication, and you're in fear of it, or you are a bit, worried about drug combinations, chat to them, talk to them, listen to some of the Facebook Lives. Go and look at the one from Matt Gurney, go and look at the one from Louise Clark. These are people that have spent years and years and years and years studying that stand there and say to you, please don't be scared of it, use it appropriately. Being on a medication doesn't necessarily mean it's for life. It's about buying you a window of opportunity to control the pain, to get rehab, lifestyle change, weight loss, and then hopefully you might even come off that medication. But please don't go, oh, that's really nice, I'm going to push it in a drawer, forget it, and I'm going to go and find something that's got label claims of ridiculousness. Don't do it. Number one, the biggie. I have to work with him, he puts up with this all day.
Don't completely rely on supplements.
Yes.
Supplements are, in their name, supplemental, and a lot of them have dubious claims. So don't pin your whole arthritis management onto a supplement.
Yeah, I think it's a fair point. So it's not saying that they don't have a role, but we're definitely seeing the vet industry, so many people that come in, they've spent £100 on 4 different pots with massive claims, cartoon joint and an owl sign, and you think, no. So
your money's better spent elsewhere.
Yes.
That's not to say that they can't be useful, but if we're talking about pain, there's no supplement out there that controls pain.
There you go, guys. So, thank you, Andy. Very grateful for your time. He will come back if you say that he's amazing. So please say that he's amazing. Thank you guys for listening. I will be back tomorrow with Diane Messam. I hope to see you all there. And we've got a jam-packed February, so stay with us. See you later.